Good morning, everyone. I'll be speaking on clinical profile and management outcomes of retinoblastoma patients presenting with orbital cellulitis. As we all know, retinoblastoma can masquerade as cellulitis in advanced intraocular and orbital stages. The inflammation is secondary to tumor necrosis, which leads to lid edema, proptosis, and other signs of orbital inflammation. Main clinical differential diagnosis is orbital cellulitis, which is infectious, and it can be diagnosed with thorough clinical and radiological examination. The primary objective of this study is to evaluate local recurrence, systemic metastasis, and survival rate in retinoblastoma patients presenting with orbital pseudocellulitis. The inclusion criteria was retinoblastoma patients with intraocular and orbital presentations who presented as orbital pseudocellulitis. It was a retrospective case series studies including 10 patients done from February 2018 to October 2023. Outcome variables were local and systemic metastasis with survival rate. All the patients underwent IV antibiotic and steroid treatment for symptomatic relief, further which they underwent systemic screening done by bone marrow biopsy and CSF cytology. Neuroimaging was done for all the patients that included MRI brain and orbit. Neoadjuvant chemotherapy was given standard or high doses for 6 cycles. Patients were re-imaged and underwent enucleation plus implant. All the patients underwent histopathological examination, out of which 4 showed high-risk factors. According to that, patients underwent adjuvant therapy, which included chemo and radio as well. So as results, the mean age of presentation of my patients was 34 months, which had male preponderance, with majority had unilateral cases, that was in 7 patients. The main symptom at presentation was eyelid edema, which was seen in all of the patients. Those were total 10 patients. 60% patients presented with intraocular RV and 40 presented with orbital RV. Intraocular RV, 33% had group E and 67% had group A with clinical risk factors. Optic nerve invasion was seen in 40% patients and systemic metastasis was seen in 30% patients. So the mean follow-up period of this study was 20 months. 9 patients underwent enucleation plus implant as 1 patient lost to follow-up after initial presentation. High-risk factor was seen in 4 patients, which included choroidal involvement, choroidal plus ciliary body involvement, optic nerve invasion. Systemic metastasis was seen in 3 patients, that is skeletal involvement, regional lymph node involvement, and meningeal involvement, which was done by CSF cytology, which showed positive results. So overall survival of the patients, 78% patients were alive and are disease-free, 11% patients are alive with active disease, and 11% succumb to death. This is the overall results review. It is a clinical picture of a right-sided orbital RV but presented with orbital pseudocellulitis. MRI image of left-sided orbital RV presenting with pseudocellulitis with optic nerve extension. This is a 10-week-old female child who presented to us with left eye group E retinoblastoma with orbital pseudocellulitis. She underwent 6 cycles of standard dose of neoadjuvant chemotherapy, further which her left eye went into phthisis and its secondary enucleation was done. Last image is the image at 24 months of age with the customized ocular prosthesis. So overall, the most common presenting feature in patients with retinoblastoma and orbital pseudocellulitis is eyelid edema. Group E was seen in 2 patients and group E with CRF in 4. So overall, we report 30% systemic metastasis with 88% survival at mean follow-up of 20 months in patients of RV that presented with orbital pseudocellulitis. Agarwal and al. In 2004 studied over 4 patients of RV with orbital cellulitis, and after enucleation, all the 4 patients had high-risk factors. Waljinkar et al. In 2013 studied over 14 such patients, and out of which 10 underwent enucleation and HRF was seen in 4. Kaliki et al. In 2022 studied over 32 patients, all of them underwent enucleation and HRF was seen in 23 patients. In our study, we included 10 patients, out of which HRF was seen in 4, and patients alive with inactive disease are 7, with active disease is 1, and 1 succumbed to death. So as a conclusion, I would like to say that orbital cellulitis-like presentation of retinoblastoma can be misdiagnosed as an infective etiology. It is highly recommended that retinoblastoma should be kept as a differential whenever a child is presenting with orbital cellulitis, and all the children should undergo imaging, because imaging modalities are the important tools which will lead to the confirmed diagnosis, optic nerve invasion or extraocular extension, and timely initiation of primary treatment can facilitate and help in overall salvage of the life.
Dr. Chowgule, sorry, I said Dr. Chowgule. Dr. Pachori, yeah, so you had 10 patients with orbital cellulitis. right? And so how many days of steroids did you give before you got the imaging done?
So at least 5 days IV antibiotics with 3 days steroids.
So why did you give antibiotics? Why did you give antibiotics?
For the symptomatic relief.
But you said these patients had pseudocellulitis.
So because patient had eyelid edema and pain also to reduce.
And that was because of sterile necrosis, right?
Yeah, to reduce those inflammation.
Okay. The second thing is, on imaging, how many patients had extraocular disease? First imaging. First imaging, yeah.
Yeah, 4 patients.
4 patients had extraocular disease and the remaining did not. Optic nerve invasion. Did anybody have orbital invasion?
At the time of presentation, no.
No. Okay. And how did you look at the high-risk factors for metastasis?
Sir, after renucleation on histopathological examination, we had choroidal involvement and we had CVD body involvement and optic nerve invasion post-lamina.
In 4 patients only?
Yeah.
And this is after 6 cycles of chemotherapy?
Yes.
You've already downstaged the disease?
Yeah.
Okay. Thank you.